Good morning, my name is Maria José. I am from Medellin, Colombia, and I'm going to present you a very challenging case we had in our hospital with this uncommon disease. Our patient is a 28-year-old female with no past medical or medication history. She initially presented to another hospital with 15 days of upper respiratory symptoms, cough, fever, odynophagia, and headache. She also developed painful ulcers on the lips, oral cavity, and genitals, with bilateral painful red eyes and photophobia. Upon admission, she was tachycardic and febrile, and presented bilateral red eyes with desquamative ulcers in both upper eyelids. She also developed prominent mucositis in her oral cavity, painful to the point of limitation to swallowing, and multiple ulcers covered by a bloody crust on the lips and oral cavity. In the vaginal mucosa, she had lacerations and friability. First lab tests revealed elevation of acute phase reactants. Initial infectious exams, including blood cultures, were negative. We performed a chest CT and revealed ground glass opacities in the right middle lobe. A few days later, our patient developed a mild rash on her chest and upper back. The ophthalmologist diagnosed her with bilateral anterior uveitis, leading to an initial diagnosis of Behçet's disease, so she was started on prednisolone and azathioprine, and then she was discharged. But 2 weeks later, the patient presented to our hospital with productive cough, worsening oral ulcers, paroxysmal nocturnal dyspnea, and orthopnea. She was also found hypoxemic. To our surprise, new laboratory exams revealed pancytopenia with 120 neutrophils and a normal autoimmune profile. So, azathioprine was stopped over hematological toxicity concerns. The steroids were gradually tapered, and oral acyclovir was given empirically without improvement of the ulcers. A new chest CT scan showed a left lower lobe consolidation, and remember, our patient had symptoms of heart failure, so the echocardiogram revealed new onset biventricular heart failure with a reduced ejection fraction of 34%, and a cardiac MRI confirmed acute myocarditis. So dermatology performed lip and tongue biopsies, which showed ulcers with inflammation with no signs of vasculitis, and they were negative for viral, fungi, and herpes simplex virus. The pathogy test was negative too. So given the mucosal and lung involvement, serological testing for Mycoplasma pneumonia was requested and came back positive, with IgM and IgG reactive. So we performed a film array pneumonia panel on a sputum sample, detecting both Mycoplasma pneumonia again and Pseudomonas aeruginosa. So we had a young woman with a severe mucositis, bilateral painful red eyes, a mild rash, and a pneumonia in the setting of positive Mycoplasma antibodies and a positive molecular test. This led us to reach the diagnosis of Mycoplasma-induced rash and mucositis. But what happened to our patient? The cell can recover after stopping azathioprine. She was treated with azithromycin and piperacillin tazobactam, resulting in complete resolution of symptoms, and then she was discharged with optimal medical treatment for heart failure. Now, let's talk about mycoplasma. Mycoplasma typically affects the upper respiratory tract, but it can manifest with a lot of multiple extrapulmonary manifestations, like anterior uveitis and myocarditis, as was observed in our patient. Mucocutaneous lesions can present in 25% of cases, usually as mild maculopapular lesion and rarely as MIRM, a recently described entity. MIRM is rare in adults, very rare. Most of the cases are in children and young patients. It's usually preceded by fever and cough, and it's characterized by hemorrhagic crust on the lips, erosion, or oral cavity, and 60% of cases can have urogenital compromise. A mild rash may or may not be present. The affection of the eyes in 92% of patients, and for the diagnosis, clinical and laboratory evidence of Mycoplasma pneumonia must be present. Conclusion: we have a patient with a severe mycoplasma infection who explained her multiple extrapulmonary manifestations, including myocarditis, uveitis, and MIRM. Neutropenia due to azathioprine toxicity predisposed her to bacterial superinfection with Pseudomonas aeruginosa. And remember, infectious causes should always be ruled out within the differential diagnosis of immune-related disease. Thank you very much, especially to the organizers of this event who allowed me to share this case with you.
Well, it must be generational because every speaker is slightly below time. In my time, everybody was well over 45-minute presentation. Dr. Singhal will be giving us her thoughts, but I see our main radiologist from Ontario, Canada, sitting up there. Julian, is there anything on X-rays, on CAT scans, which could point towards mycoplasma, rather than something else? Are you of any use in this department?
No,
Okay. Okay, so nothing specific.
nothing specific, no.
okay.
But it can narrow down the differential diagnosis to something that's inflammatory or infectious.
You can distinguish between inflammatory
No,
and
no, but it can exclude
Okay.
everything else and then narrow it so then you
Okay,
can
to
focus on those
inflammatory,
two
but you
areas.
don't know which one.
Yes.
Okay. Professor Singhal. No, whoa. Yeah.
Thank you for that excellent case. That was wonderful. And thank you for the plug about always trying to rule out infectious causes. As I'm sitting beside a rheumatologist and we were just talking about how there's so much overlap, and usually it goes the other way around where we rule out the infectious cause and then send them over to our rheumatology colleagues. But I was also just curious about the original diagnosis of Behçet's with the ground glass opacifications that we're seeing on CT scan. Was there an explanation, or how was that sort of tied together? In my
Yes.
experience, I've not seen a lot of lung involvement in
That-
Behçet's, but I can pass it over to Dr. Legault.
Yes, that happened in another hospital, but when we reviewed the clinical history, we saw that chest CT, they didn't see that. So after that, we gathered all the information and we saw the pulmonary compromise. So we thought, like, with the ground glass opacity, this can be an infectious cause, and it's always very, very acute. It's a very acute case, and it was the first time with those ulcers. So the Behçet's disease, it's a diagnosis of you have to rule out other infectious causes before diagnosing that.
And can I just ask another question? I know you talked about giving them antibiotics, but with mycoplasma, as we know, there's protein manifestations, especially when you get into more autoimmune. And my understanding of the mycoplasma-induced rash and mucositis is that it's felt to be a bit immune complex mediated. And so I was just curious if you had also given them steroids, or if it was really just the antibiotics alone that you had treated them and they improved on.
To our patient, we didn't give her steroids, but in the literature, there are some cases around the world with MIRM, which are treated with steroids, and with some cases with immunoglobulin too. But our patient just antibiotics and topical treatment for the ulcers.
Can I ask a question?
Any other?
Yes.
Oh, go ahead, sure.
Excellent presentation, nice case.
Thank you
My
very
name is Reinhold Kreutz, I'm from Berlin. I was wondering, when the diagnosis was confirmed based on your serological tests and PCR for mycoplasma, why you selected, in addition to macrolide, beta-lactam antibiotic, piperacillin, probably does not work against mycoplasma. So my question is why you used it in addition, why did you use piperacillin, a beta-lactam antibiotic?
We use both azithromycin and piperacillin tazobactam because remember that our patient in the film array had mycoplasma pneumonia and Pseudomonas aeruginosa. It was for the Pseudomonas aeruginosa, which was acquired, a pneumonia, hospital acquired. That's why we gave it. But yes, the azithromycin was for the mycoplasma.
Okay.
Well, thank you very much. We'll have to move to the next one. I know that
Thank you very
jury
much.
will have incredible, difficult task by now.